Good morning. It is Thursday, April 6th. I'm Jessica Lovell. Welcome to the Morning Medical Update. Yesterday, the University of Kansas Health System received and cared for multiple shooting victims with non-life-threatening injuries. KCK police reported that 3 of those victims were police officers. Joining us now this morning for an update is Dr. Sean Coomer, Associate Chief Medical Officer here at the University of Kansas Health System. Dr. Coomer, what can you tell us this morning?
Good morning, Jess. Thank you very much. This is obviously an ongoing criminal investigation. The Kansas City, Kansas police have asked that their agency provides updates on the medical conditions of their officers, and we expect them to have an update later today. As we mentioned last night, these were all non-life-threatening injuries for the police officers.
So, Dr. Coomer, yesterday's incident involved several victims arriving all at once at the emergency department and numerous other police officers all coming here to our campus. So how did the health system respond?
Well, this is obviously a testament to our people. We have a great system here, the trauma team, the emergency department, and all that support that. It's really a well-oiled machine. When we have multiple victims coming in and to care for all of them at the same time, it is challenging, although it is something that they are completely prepared for, and we're extremely proud of how they responded.
Dr. Coomer, anything else you can tell us this morning?
Well, you know, again, the KCK police have asked that if there's any information on the shooting, please contact the Kansas City, Kansas Police Department. I really want to say a personal thank you to the support and cooperation that we got from the public, as well as the media, as well as the police departments of both Missouri and Kansas City, Kansas. We're so grateful that the injuries on our police officers that keep us safe every day are non-life-threatening, and they are progressing well in their care.
Any reporters on the line with questions for Dr. Coomer? All right, Dr. Coomer, thanks for the update. We'll let you get back to work. Thank you.
Thank you.
Cancer treatment is bad enough, but when COVID hit, it complicated the cancer journey for one young mom. Today, we have even more proof that colorectal cancer is no longer an old person's disease. We'll hear how another young patient faced her diagnosis and highlight the importance of listening to your body. We've shown you this graph before. It's the newest numbers on colorectal cancer from the American Cancer Society. Over 20 years, cases are dropping for people ages 65 and older, but at the same time, cases are creeping up for adults under the age of 50. This is why younger people need to be aware of the signs and the symptoms. So to help us better understand what we're looking for, we are joined by a colon cancer survivor, Beth, who asked to only use her first name this morning. Beth, thank you so much for being here with us and willing to share your story. How are you?
Hi, good morning. Thank you for having me.
We're also joined by Dr. Anup Kasi, hematologist and medical oncologist at the University of Kansas Cancer Center. Dr. Kasi, good to see you.
Nice to see you too.
Thanks for being with us. He is an expert in gastrointestinal cancers, including colorectal cancer. And Beth, you learned you had colon cancer in October of 2019. How old were you when you got that diagnosis?
I was just 31. Yeah.
What was that news like for a 31-year-old young gal?
Well, I mean, I had a 15-month-old baby at home, and so for me, it was super startling. It was something I didn't expect, and not something that the doctors I had seen had brought up as a possibility. So it was definitely a shock.
And you mentioned the little ones at home. Tell us a little bit about your family as we go through some of these photos.
Yeah, this is obviously post-treatment, but I have 2 boys now. Joshua, my oldest, he is almost 5, and Casey is 20 months old now, and I had him naturally after stopping chemotherapy.
So Beth, before that diagnosis, what kind of symptoms were you feeling, and for how long were you feeling those before you sought help?
Well, by the time I got a colonoscopy, it had been about 9 or 10 months of having symptoms. I think when I first started feeling off, I had just finished breastfeeding, and I thought, well, this must just be hormones or something is fluctuating, and I don't know what's causing this. Some things I'm just irregular. And then talking to my general doctor and my OB over appointments over the next few months, we thought maybe it was IBS or some type of gluten allergy. And so I get in to see a GI specialist. And they tried different diets. None of that works. And it was finally the colonoscopy that discovered the cancer.
And our bodies, I mean, they're just so weird after having babies. You think it could just be almost 100 different things. You just attribute it to that cute little baby at home, and you just kind of go with the punches and say, hey, that's the price you pay for having a kid, right?
Right.
Well, so you get this colonoscopy, and it's recommended for people over the age of 45. So you get it. And then how quickly did you start treatment? What was that treatment after you got diagnosed?
Right. So I had the colonoscopy. I remember it was October 4th. And then 6 days later, I had surgery to remove a portion of my sigmoid colon. So it was very quick. It happened, that was a whirlwind week. And I think I waited about 6 or 7 weeks before starting chemotherapy after that to recover from the surgery.
Dr. Kasi, we all know how important it is to spot cancer early, get those screenings. We can't say that enough, but try to nail down what symptoms people should be looking for so they know when to go see a doctor and to not push it aside, not blame it on the new baby or the pregnancy body or just getting older.
Right, that's a good question. I know that can be, challenging, especially if, colorectal cancer is not on your radar. So from that standpoint, paying close attention and listening to your body, any change in bowel habits that you see, narrow caliber stools, abdominal pain, pressure, pelvic pressure with bowel movements, blood in stools. I mean, those are red flags to look for.
And we know people, it's kind of an embarrassing conversation to have, but we talk about it very openly on this show. We show pictures of colonoscopies. We talk about the bowels and, blood and stool, and we say all the words. So, Beth, I'm going to ask you, how do we make people feel more comfortable talking about these, what some people might think are kind of embarrassing symptoms, but to just bring them out in the open and let's talk about it?
I mean, I think something like this is a perfect example. While it still can be a little bit uncomfortable for me, this is why I push myself to accept doing things like this for advocacy and for somebody to see that it's not a 70-year-old man that is on the side of the screen that had colon cancer. It's somebody who was young and had their whole life in front of them. So, I mean, that for me, that's what it is.
And that's why you're here. I mean, to be that face, because you could be the face of thousands that we're trying to change all that. So we had some photos of you and your family in the hospital with you. That's a struggle. No mom wants to be in the hospital laid up when they've got little ones to take care of. And you're FaceTiming your little baby at home. What was that like for you?
Oh, I mean, this was pre-COVID, so it was kind of, he wasn't going to come up and visit me in the hospital. That right after the surgery, but I think that was the either night or the next morning after. Just it was weird for him not to see me every day, so I wanted to keep it a little normal for him and to see me and to let him know mommy was okay. And
yeah, good thinking. So everyone has heard how awful chemotherapy can be, but you lived it. How did chemo make you feel physically day in and day out?
The most surprising thing about chemo for me was the exhaustion. I mean, I know everyone told me you're going to be really tired. You need to do less. You need to plan to do less. And I was shocked by how exhausted I was to do simple daily tasks. So for me, that was the hardest, just to not have the energy to do what I wanted to do with my family. Of course, every chemo drug is different, but the regimen I was on, 1 week that I had chemo, I would feel pretty sick, but by, a week later, I was starting to feel better, and then I'd have a good week and then a bad week and off and on. So it was nice to be able to have a bright side of you don't feel sick 100% of the time. You get through the week and you get on to the next week and you have a good week.
Right, you have a little bit of relief. That works well when you're trying to handle a family at home. Tell us about that chemo port that you had in your chest. What was that like living with that?
I really didn't like my chemo port. I actually had to get two. My first one didn't go very well. I had some complications. So right after my first session, they took out my original chemo port and put another one on the other side. So I was healing from one chemo port being taken out, and then had the surgery of the uncomfortableness of having it put in. Once you get used to it, it's fine. But but obviously you can't sleep on your stomach or anything like that. And wearing a seatbelt is different, and picking things up and stretching, you always just feel that it's there. It's a reminder.
So you're glad to have that out. Dr. Kasi, why does everyone have a port when they're going through chemo?
Yes and no. I mean, I would say the majority of them, we do encourage a port. And the reason being, it helps with delivery of IV chemotherapy on a schedule every 2 weeks for our patients. And going through their peripheral veins can be difficult.
So it's a hassle to do it the other way. So if you can get used to it, get used to it. But Beth, we know there's a mental side to this journey. How did you stay sane through it all?
I think at first, in the beginning, it's happening, and it's happening fast. But I woke up and realized, like, this is the only way through it is through it. And so this is the plan, and this is how we beat the cancer. And that's what kind of kept me grounded to getting through it, and being and still being present with my family, and getting through the treatment.
And we know, cancer, it's a family affair. How did your husband handle this? Other parts and other people in your family?
Amazingly, very supportive. I'm lucky to have a good support system. My parents, right at the first month, basically moved into the house and helped us and helped my husband. At the same time, he had actually lost within the same month of me being diagnosed with cancer, he had lost his mother due to a sudden heart attack. So it was like everything was happening at once, and he was grieving that, but also grieving our cancer diagnosis. So having people around you that just kind of swoop in and take care of stuff without you knowing is really important.
Yeah, you never realize how strong you are. Then you get a 1-2 punch like that. Speaking of family, though, you were young enough that fertility was a consideration when you started your treatment. I understand you had some eggs preserved. Is that correct?
Yeah. So that was one of the main. Dr. Kasi was the second doctor I saw. I had been to a different hospital and then got a second opinion with KU. And Dr. Kasi was very vocal upfront about saying you should preserve your eggs. And that wasn't even a discussion I had with another doctor. And I thought, wow, you're right. I need to do this like right now. They fit me in at the KU clinic in between my surgery and cancer, and we were able to successfully retrieve eggs to put in storage.
And Dr. Kasi, I mean, when you're getting a cancer diagnosis, your future family, having children, getting pregnant is the last thing you're thinking about. But our team thinks about that for you. That's something. Talk to us about that. Why that conversation is something that you present to patients very early on in their cancer treatment, before they even start.
Yeah, no, absolutely. Because, once we start them on treatment, especially like chemotherapy-based treatments, then it does suppress their ovarian function, and there's risk that, the ovarian function may not return. So in patients who are especially with this rising incidence of colon cancers and other GI cancers in the younger population, then it's more and more important to focus on family planning and fertility preservation for our patients. So we have a team. It's a team approach here. It's a multidisciplinary team approach, and so it's part of our a process in terms of assessing the needs for our patients comprehensively, and one of them happens to be fertility.
So during Beth's treatment, the COVID-19 pandemic started. Chemotherapy patients, as we know, are at extra risk due to their immune systems being so suppressed. How did the pandemic change things for the typical chemotherapy patient?
Oh yeah, I mean, I think it changed it radically, especially during the peak of the pandemic. We had to make some changes, obviously, as simple as changing our appointments from in-person appointment to telehealth, especially for patients that are on observation or surveillance. But obviously for patients that are on chemotherapy, they have to be seen in person. We had to modify their chemotherapy a little bit, including more supportive care, such as growth factors, such that their counts don't go down, and put them at risk of infections, including COVID and the severe infections. So there was quite a bit of changes that we had to make.
And this is not the first time we've heard this story lately. Beth, we understand you ended up stopping your chemo during the pandemic. What went into that decision?
I was scheduled to do my 9th chemo session. I had gone into KU, and like I always did, I met with Dr. Kasi after my labs. and he sat down, and I really didn't know much about COVID. It was like the week that everything was happening, and he explained to me about the decision to stop chemotherapy, and we weighed the risks and benefits. At first, I was in tears. I was upset. I thought we had to be super aggressive in order for me to beat this cancer. It's not fair that I have to stop. I need to finish all of this. But then after a couple days of thinking about it and researching, it made sense to me, and it ended up being really a gift that I didn't have another 4 treatments of chemotherapy running through me, that I would have to deal with more severe long-term side effects.
Be sure to ask your questions. You can use the chat on YouTube or Facebook. You can tweet us or email us at the Medical News Network. You can find info for those right there on your screen. Let's get a quick check on our COVID count. Dr. Dana Hawkinson, good morning.
Hi, how's it going?
Good.
Good, yeah. So today in the health system, again, luckily we have started to see our numbers decrease a little bit. Let's hope that continues through the end of this week and into next week. But 38 total cases, 20 of those are active, 5 in the ICU and 3 on the ventilator as well. So hopefully we are starting to see a downtrend, but we've said that before. We just have to wait for the data.
So the newest CDC data shows that tuberculosis, do I have to say tuberculosis this early in the morning? I don't know, my tongue's warmed up. So we know that these cases rose for 2 straight years. Cases had dropped during the pandemic and still had not returned to pre-pandemic levels. What are your thoughts on this? What does that tell us?
Yeah. Those multi-syllable words certainly are harder in the morning. Tuberculosis.
Thank you.
TB is what most people know. Certainly we had some good data before the pandemic showing decrease in rates, but I think we have started to see increasing rates, and that is a multifactorial issue. Again, during the pandemic, a lot of surveillance programs went away, a lot of treatment programs went away. People weren't going to the doctor, so I think all of those things add in. We have seen also, anecdotally through my practice here with me and my partners, at the health system, we have seen more and more active TB cases as well. Luckily, we have strong relationships with local health departments, including Wyandotte County Health Department, Johnson County Health Department, and even our partners on the other side of the state line. So as a community, we are doing all we can do to diagnose, evaluate, and certainly treat these active cases, but this is a problem in our nation, also worldwide. But this just goes to show you, there are more things in COVID out there for sure, and it is a constant battle with us and other microorganisms. But it is concerning, so we just need to be vigilant, continue to have our surveillance programs, continue to have our public health infrastructure so we can get people who may not have those resources get access to resources for diagnosis and treatment as well.
It's TB from now on for me.
TB.
TB.
That's good.
All right, Dr. Kasi, when someone is in remission, it's important to keep checking to verify that the cancer has not come back. In Beth's case, you told us about a new technology, a new blood test to check for that. Tell us what it is and what it's called.
Yeah, so the blood test that we used in Beth's case, at that time, I remember it was still, early in its use, and she was one of our first patients that we did this test on. It's basically what we call a circulating tumor DNA. So we take the blood sample and look for floating tumor cells and tumor cell fragments or DNA in the bloodstream, and then compare that. So there's a signature we develop with that, and compare that to the surgical tissue where the cancer tissue was resected, and see if the signature matches.
So what would you have done before? How would you check on her cancer before? Just versus this new blood test. What was the difference?
So before we had to go by the patient's symptoms, imaging, standard imaging like CT scans, which has a certain threshold in terms of sensitivity for detection of cancers, and also another blood test called CEA, which sometimes can be non-specific or even normal in some patients. Tumors may not produce that marker called CEA.
And how are you feeling about the accuracy of this new technology and blood test?
Yeah, I mean, it is very accurate in terms of its sensitivity as well as specificity. So that's how precise we can get. When we look at all the studies, it ranges 80 to 90% in terms of its sensitivity and specificity.
I cannot ask this question enough, but with this trend of people under the age of 50, I mean, we're seeing 20, 30, 40-year-olds with colorectal cancer and disease. Do we know why? What are your theories?
Yeah, I mean, that's a great question. I think we're still trying to figure this out. I think it's multifactorial, several factors. One, the big thing I think would be lifestyle and environmental factors, obesity, sedentary lifestyle, unhealthy eating habits, those are big things. And more, data and research is pointing towards the host factors, which is the microbiome, the bacteria within the gut. And all the exposures that we've had in the past, for example, antibiotics that people are exposed to early on in their childhood. So a lot of those things can, increase, can add on and be risk factors. So we're still trying to understand. I think with more and more research, multidisciplinary approach, hopefully we get to that answer soon.
Answer the mystery that's been looming.
Exactly.
Do we have any reporters on the line today? All right, let's get to some community questions. Lynn wants to know, did Beth talk about cancer with her children? What advice do you have talking to children about cancer?
We did, in a way, like what was visible, like my healing wounds or my chemo port. We'd say, this is mommy's owie, she's being treated, she's sick. Somebody gave us a book that was like cancer. I think the title is Cancer Hates Kisses, and we would read that book every once in a while. But at the time, it's just a toddler. But now my oldest definitely understands when we have good news, and we can celebrate I'm still cancer free. He does seem to understand that better.
And I have a question, Dr. Kasi. Terry wants to know, any advice on making colonoscopy prep any better? We hear the prep is worse than the actual colonoscopy, and it's so true. But is the prep just worth what we're finding out in there?
Yes, absolutely. I mean, I think colorectal cancer is a preventable cancer. If it's starts as a polyp, and if we can cut it out, then the precancer is out. Or even early stage, very early stage, stage 1 type of cancers could be cured with a polypectomy through a colonoscopy. So it's certainly worth doing it. I know the prep is hard, but I think our gastroenterologists do have some other alternative preps, including a 2-day prep instead of a 1-day prep, split prep. So I think I would certainly discuss that with your gastroenterologist to see how to make that, more feasible or more comfortable, if you will.
Yeah, I know. It's a tough one, but you get through it. Dr. Kasi, I know you have to go get to a patient, and I'm going to let you do that. But before I let you go, any final thoughts, any message you want to make sure the public knows about screening and detecting early cancer?
Yeah, I mean, I would say, colorectal cancer is on the rise in our younger population. So, pay attention to your body, your symptoms, and if you need a colonoscopy done sooner than 45, then we should go ahead and do it.
Dr. Kasi, always good to see you. Thank you for being with us today.
Thank you.
Appreciate
Thanks for having
you.
me.
Question from Jean for Dr. Hawkinson. Yeah. How do we explain the higher number of acute COVID patients right now?
Yeah, I don't know that it's higher. We have seen numbers up to the 40s. A lot of times these past few months, really, we've been in the upper 20s, lower 30s, even mid 30s. So unfortunately, we are still seeing the virus is circulating. Really, a lot of these patients that are coming in with acute illness have other comorbid conditions. I think that's what it is. Again, we have also seen severe disease. We do have a high proportion who are in the ICU and on the ventilator compared to the total number of acute patients. So I think what it means is the virus is still circulating. We need to do everything we can for prevention. Be up to date with your booster. Most importantly, if you have symptoms, especially if you're at high risk, get tested early and get on Paxlovid. We know Paxlovid can reduce that chance of hospitalization, severe disease. And just a little bit of 2 cents for the question about the colon prep. Actually, Jessica, you and I had the colonoscopy last year. The colon prep that Dr. Ashcraft gave us or gave me, it's not so bad doing the prep itself. It's the 6 or 7 hours that come afterwards to really get ready.
Exactly.
So.
Although that big thick drink isn't pleasant, but it's the it's the hours that follow.
Yeah.
But other than that, it's smooth sailing, right? Although
Yes.
I think Ashcraft made it extra potent for you and me for some reason.
No, I think it was really good. Yeah.
It was good. Good stuff. All right. I want to get to some of our takeaways today. We heard from Dr. Kasi, and I want to get today's takeaway from you, Beth. What do you want our audience to know?
Yeah, I think just being an advocate for yourself, especially if something feels off to you in your gut, literally and physically. So yeah, if something's off, just keep pushing. Don't just accept when a doctor may say like, oh, this is normal, just watch it for a little while. and I'm not saying we have to overreact, but definitely question, because you are the only person that can really be your own advocate in those circumstances. So making sure that you're taking care of yourself and doing that work is important.
Yeah. Beth, you nailed it. It's about questioning doctors, and a good doctor doesn't mind if you do your own research and ask your own questions. So absolutely, be your own advocate. Thank you again so much for sharing your story and just again being that face. And hopefully you've got somebody to wake up and listen today and make that phone call. So we appreciate it. Dr. Hawkinson, today's takeaway.
Yeah, I think that is the takeaway. Be your own advocate. Continue to ask questions. Certainly, when I'm seeing patients in the hospital or in the clinic, I always encourage them to ask questions. Continue to ask questions. We will try to give you the best answer. Our job is to give you the best answer so that you can make that informed decision. And though we haven't said it in a long time, if you don't like those answers or don't like what is going on in your care, in the course of your care, it might be time to seek a new medical team or a new physician as well. So it is vitally important to keep asking those questions and get those reasonable answers that you trust.
Yep, good advice. Doc Hawk, thanks so much. All Things Heart is coming up at 10 a.m. Alexis Del Cid joins us now with a preview. Hey, good morning.
Good morning, Jess. And this morning we're talking about a topic that nobody likes to talk about. We're talking about varicose veins. We're telling the story of two different patients. One is a young woman. The other is a legendary Kansas City entrepreneur named Bob Trapp. You might recognize the name. What happened to Bob Trapp was really alarming.
I didn't know what to do. I didn't know how to stop the bleeding, and it was really bleeding.
What happened to him can happen to anyone with a varicose vein. That might surprise you. We're going to explain the potential dangers if you don't get your varicose veins treated, how you can take care of them, where you can take care of them, and you might be surprised to learn that in many cases, it's a cardiologist who performs that procedure. We will be joined live by a young woman and the cardiologist here at the University of Kansas Health System who took care of her varicose veins. She is thrilled with the results. That's coming up at 10 a.m. Bring your questions. We know our viewers have plenty of questions and we love them.
Yes, we will check it out. Alexis, thank you so much. And thank you to all of our guests today and, of course, to our viewers for being with us. We'll see you back here tomorrow at 8. Coming up tomorrow on the Morning Medical Update. After a heart attack and triple bypass, one patient got even more bad news. A crucial artery was completely blocked. I'm Jessica Lovell on the next Morning Medical Update. The life-saving procedure that didn't even require anesthesia. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.